Good morning, everyone. It's my pleasure to welcome Dr. Montgomery
Recording in
to
progress.
Minneapolis. And we are looking forward to seeing her in person tomorrow when she arrives for the ET Bell. So for an introduction, Dr. Montgomery started her career in the military. So after graduating from the Johns Hopkins University in 1980 with a degree in chemistry, her military experience was between 1981 and 92, and she attained the rank of major in 1990 before she was honorably discharged in 1992. During her military career, she obtained her MD diploma in 1984 at the George Washington University, followed by internship and residency in anatomic and clinical pathology at the Walter Reed Medical Center, which she finished in 1988. She was appointed staff pathologist at the AFIP from 1990 to 92 in the Department of Soft Tissue Pathology. And then she served as clinical assistant professor in the Department of Pathology at the George Washington University. Following her discharge from the military, she continued her role at George Washington and gained promotion to associate professor in 1995. She joined the Johns Hopkins University Department of Pathology in 1999 as an associate professor and director of clinical GI pathology. On all her time at Johns Hopkins, she wore several hats during that time, including being joint appointed to the oncology division and running a lot of the fellowship positions right there. So in her own words, she said she was academically considered qualified for rank of professor by Professorial Promotions Committee, Johns Hopkins University in April 2005. Among many other positions, she has been the editor-in-chief of the American Registry of Pathology Press, the 5th series of the AFIP fascicles and atlases, which is a volume that we are aware of. In July 2020, Dr. Montgomery moved from the DC area. After virtually having had all her career and education in the DC area, she went to the University of Miami, Miller School of Medicine, and took on the role of the vice chair, anatomic pathology. Without counting case reports, Dr. Montgomery has published more than 360 peer-reviewed manuscripts. And that's also not including book chapters, which is about 67 or so. She's also being the editor of 26 book volumes. So, and all these publications have been as a world-renowned expert in two major anatomic pathology subspecialties, which is the soft tissue pathology and GI pathology. She has been the PI on several NIH, NCI, and several other external grants and internal grants. So she wants me not to make too much fuss about her credentials. So I'm just going to pause there and give her plenty of time to give her talk, which is titled Gastrointestinal Tract Mesenchymal Neoplasms. Location is everything. Thank you very much, Dr. Montgomery. So the screen is yours now.
All right. Well, thank you for that very kind introduction. And I guess I'll share my screen now. And here we go. Okay. Oh, yeah. I guess y'all want to see the talk. I guess I need to start that. Here I go. Can you hear me?
Yeah, very well.
Okay, good. All right. Here we go. So we're going to talk about some GI mesenchymal tumors, as we've discussed. And of course, the main thing is all about tying in morphology with what we know with modern science. So of course, I'm going to move the people so you can see the words. One moment. So of course, what we're going to do is discuss the layers of the GI tract where we might expect different types of tumors. Of course, we'll have to talk about a few specific types of tumors and where we can expect them in the GI tract. And we will talk about how we might distinguish some of the mucosal-based nerve sheath tumors, because we see those a lot. So I think that the secret with mesenchymal tumors is knowing exactly which layer the tumor happens to live in. So let's see, can I put this sideways? Oh, I can. So for example, platelet-derived growth factor receptor alpha mutations are seen in two very different tumors, inflammatory fibroid polyp, which is almost always in the submucosa, and gastrointestinal stromal tumor, at least a subset in the stomach, and they're virtually always in the muscularis propria. So pay attention to location, just like when you buy a house. So as an example of this general concept, this is a picture of the esophagus. You can see I've mentioned some of the spindle cell tumors that we might encounter in the esophagus. In fact, this is a little misleading because often we'll see leiomyomas, in fact, in the muscularis propria. GI stromal tumors are very rare in the esophagus, but when they occur, they tend to be malignant. Now we're getting into the stomach. Notice I haven't highlighted the mesentery, but you can get mesenteric tumors in the stomach. And the things we see in the stomach revolve around the submucosa, inflammatory fibroid polyp, and then this set of suspects here. As we get into the small bowel, we begin to see a lot of mesenteric lesions. So here's where you'll start to see the most fibromatoses and similar things. And as we get into the colon, okay, I guess this picture is not going to work. We begin to see the mesenteric fibromatosis and all of these other things from the mesentery, but this is where we start to see lots and lots of little mucosal nerve sheath tumors that I've listed at the top. So we're going to start on the outside and work our way in. Let's look at a few mesenteric processes. And the first of those is inflammatory myofibroblastic tumor, henceforth IMT. Everybody on this call who's old like I am, I guess Dr. Khalifa's not quite as old as I am, but he's working on it, might have noticed that we were taught about things that were called inflammatory pseudotumors of the lung. We were taught that they were in a spectrum with so-called plasma cell granulomas. And over time, we began to realize that these tumors could be found anywhere. And the characteristic lesion was in the abdomen. This is a great big mass that was in the mesentery of the small bowel of a child, in fact, who presented with B symptoms, the classic presentation. And of course, sometimes these things can extend up into the muscularis propria. You can see that I've shown stomach here, but you can see also that the tumor really has barely made it into the muscularis propria. This is a gorgeous example of an IMT that happened to arise in the gallbladder. So the patient presented with cholecystitis, and you can see the gallbladder epithelium. And then you can see this lesion that's basically transmural, but centered out in the mesentery. And here's very high magnification of an IMT. That was the gallbladder one. And you'll notice that each of the proliferating cells has a macronucleolus. Because of this feature, in fact, when these were very first described, the term that was used was inflammatory fibrosarcoma to underscore these macronucleoli and these enlarged cells. Notice also the very nice stellate cytoplasm that's amphiphilic, i.e. neither eosinophilic nor basophilic, that's very characteristic of myofibroblastic differentiation. I'm sure you also noticed the backdrop of plasma cells. In 1999, Constance Griffin, who was my former colleague at Johns Hopkins, observed that IMTs had rearrangements of the 2p23 chromosome site involving the ALK gene. And over time, we've learned that the ALK gene in IMT can be rearranged with a number of partners. And of course, we can find these IMTs all over the body. There's a picture of the late Dr. Griffin. She passed away from pancreas cancer some years ago. I'm not doing a HIPAA violation because it was in the newspaper. And of course, here's a beautiful example of a fluorescence in situ hybridization preparation showing a beautiful ALK rearrangement. Here are the genes that are opposed. Here's the ones involved in a rearrangement because, of course, the chromogens of each color were hybridized to either side of the known breakpoint in chromosome 2p23. Of course, what we do in real life is much cheaper and quicker, and that's to do immunohistochemistry for ALK. This is, again, that gallbladder lesion. And what I think is nice about it is it allows us to see the very prominent cytoplasm in many of the lesional cells in this case. And you kind of get a hint of that stellate cytoplasm in a cell such as this, with processes going every which way. The pitfall with inflammatory myofibroblastic tumor is that it's not uncommon to see ALK expression in these cases. So here we are, or no, I'm sorry, not keratin expression, sorry. And in the first series, in fact, about 3/4 of the tumors showed at least focal keratin, which I think is quite astonishing because, of course, as you know, that can take you down a garden path into diagnosing a sarcomatoid carcinoma. So what's really cool, of course, about the ALK rearrangements is that they're targetable. And this, of course, came about from research on lung cancer. 5% of lung cancers have targetable ALK rearrangements, which is kind of sad because it's only 5%. But of course, lung cancer is super common. So 5% of a giant number is helping a lot of people. Of course, about 60% of IMTs have ALK rearrangement. So it's pretty cool that they're targetable should they decide to behave in a bad way. Of course, most IMTs are fairly indolent and can be treated by tincture of stainless steel, i.e. surgery alone. So with these beautiful target therapy for the ALK rearrangement that's even taken by mouth, it's really been a big change. And finally, targeted therapy was shown to be effective in IMT in 2010. And of course, now there are newer molecules that generally end up being validated for lung cancer, but used for IMTs that are aggressive. In fact, the good news is that if the patient's IMT doesn't have an ALK rearrangement, there's a good chance it will have a ROS1 rearrangement. So that's a nice subset on top of the 60%. That gets you up to, I think, more like 75, 80% with the ROS rearrangements. And of course, the ROS1 rearrangements are targetable with the same compounds as ALK. And then now we're starting to see NTRK rearrangements in ALK negative IMTs, and those are also targetable. All right, unfortunately for the patients, there is a high-grade variant of IMT, and that has a fancy name. It's called epithelioid inflammatory myofibroblastic sarcoma. Yours truly has misdiagnosed these as epithelioid leiomyosarcomas in the past. I know this for a fact. This was described in 2013. I'm proud to say at least I did it wrong before it was described, but then you go back and probably a lot of things that we diagnosed as epithelioid leiomyosarcoma are in fact these high-grade IMTs. And of course, those of you who do gynecologic pathology know that some of them are probably also picomas, but that's another story. So this is what one of these high-grade type IMTs might look like, these epithelioid inflammatory myofibroblastic sarcomas. This one happens to be in the colon mesentery. And you'll see it's quite different from what I showed you before. The macronucleoli remain our friend, but now the inflammatory backdrop consists of acute inflammation. I've taken a picture with a neutrophil in the field. And when you do your ALK stain, yes, it stains, but it's weird. So this is the kind of staining you might see in one of these high-grade variants of IMT. And you'll see it kind of hanging right along the nuclear membrane, and that's because typically the fusion is with RRBP1, which lives right along where the nuclear membrane is. So it's almost like you've done a fancy molecular test just with an immunostain. And of course, we all know examples of that. So here we go. This is another one that I saw in a needle biopsy. And the clue for me to work it up for IMT was the presence of this peppering of neutrophils in the background. You'll also notice that the nuclei are pretty monotonous, which is a typical feature of these types of tumors that have designer rearrangements. It doesn't always hold, but it's a good clue to think of a tumor with a fancy rearrangement if you see nuclear monotony as opposed to nuclear pleomorphism. All right, and this is that second one. In this case, the preparation is a bit overstained, but we have this perinuclear ALK staining. This probably had a different rearrangement because it's not in a smooth line along the nuclear membrane. So of course, the good news is that there's a lot of targeting that we can do. As an aside, I would like to mention IGG4 related fibrosclerosing disease. This remains poorly understood. It's steroid responsive. It overlaps with a host of immune diseases. But the pitfall is that, and I don't know about your clinicians, but for a while, ours were saying, oh, do IgG4. And it makes sense if everything fits, but it just provides useless information if everything doesn't fit. So let's look at some of the histologic criteria of IgG4 disease. I'd like to first mention, of course, that for the older folks in the group, there were all these entities that were considered specific to various organ systems that really now are under the umbrella of IgG4 related disease. Something outside the umbrella is inflammatory myofibroblastic tumor, and sort of halfway in the Venn diagram is so-called sclerosing mesenteritis. But I know when I was a student, I was taught about retroperitoneal fibrosis and Rydell's struma and these orbital tumors and Kuttner tumors of the salivary glands. And really all that is subsumed under IgG4 related fibrosclerosing disease. If you do an IgG4 stain on an IMT, however, you will see staining. Don't let that take you down the garden path. No, 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 don't do it. So this is what you might see in bona fide IgG4 related fibrosclerosing disease. Your big friend is this storiform fibrosis demonstrated here. So there's all these fascicles going all these different ways. You can see the inflammatory backdrop. And the real big helpful feature in most cases is the obliterative phlebitis. I realize that colleagues like to take the pancreatic cases and subdivide them into 50 million categories, but I'm talking about kind of the global appearance. So what you'll see in this image is right here, you see this nice artery that I guess we didn't get a very good cut section of it, but it doesn't have a lot of damage. On the other hand, this is the remains of a vein that's been obliterated. And to look for these, you want to find yourself arteries as you look at your slide and then say, okay, where's the arteries, buddy, the vein? And if you can't find it, it's probably been obliterated. If you're like me, you need all the help you can get. So what I often do is an elastic stain or a Movat stain. So in this particular case, we can see our nice artery with its nice dramatic elastic, and then you can see the kind of footprint of the elastic of the adjoining vein. Of course, in this case, we can see the lumen, but they're hard to see on H&E in this very inflammatory background. All right, so what causes IgG4 disease? Unfortunately, I don't think we really know. There have been some very provocative studies. For example, in 2009, some colleagues in Italy said, well, gosh, maybe there's a link with Helicobacter pylori. And now if you happen to get a case of Helicobacter pylori gastritis and you do an IgG4 stain, curiously, you won't see much. On the other hand, if you get a case of autoimmune gastritis and you do an IgG4 stain, you see a lot. So it's a little bit of a screwy link, and there's also a link between H. pylori and autoimmune gastritis. So this sort of hasn't gone anywhere. On the other hand, more recently, 2019, in another holy book of medicine, so I think NEJM is a holy book, and certainly science is a holy book, these colleagues in Japan then said, well, wait a minute, there's this unmasked laminin subtype, it's basically, laminin, basement membrane stuff, that is the target antigen. But wait a minute, we all have laminin. So come on, guys. So not sure if any of this yet really means much, but these are some of the observational studies. All right, so what can have lots of IgG4 positive plasma cells? Well, you can see there's a whole lot of stuff. And it doesn't really matter if you screw up most of these and call it IgG4 disease, but you do not want to screw up calling an infection IgG4 disease and buying the patient a course of steroids. So be careful. And then, of course, some of the MALT lymphomas, the mucosa-associated lymphoid tissue lymphomas, in fact, probably are in a spectrum with IGG4 disease. Okay, switching gears, we're still in the mesentery. I'm slow as molasses. And let's look at a large mass resected from the mesentery and jejunal wall of a young woman. Here it is grossly. Here it is at low power. Sorry, it's a little extra pink. Here it is at intermediate power. Here it is at high power with a kit. So hopefully all of you have formed an idea about what this might be, and it's a mesenteric fibromatosis. Mesenteric fibromatosis, of course, can be a component of FAP. Then we talk about Gardner's syndrome. And of course, familial fibromatoses have APC mutations, whereas sporadic ones tend to have mutations in CTN and B1, the gene that encodes for beta-catenin. So fibromatoses are common. In any big city, you'll see them a lot because new cases account for 2 to 4 individuals per million per year. In children, there's gender parity, and they're usually extra-abdominal. When women have a lot of estrogen running around, they tend to be in the abdominal wall, and there's a massive female predominance. And then with increasing age, there's, again, gender parity. And what do we see? We see long fascicles of myofibroblasts and fibroblasts, infiltrative growth, and I want to draw your attention to the vascular pattern. So, of course, if you're struggling on a needle biopsy, you can take advantage of beta-catenin immunohistochemistry, which accumulates in the nucleus, and we don't see it in GI stromal tumors, thank goodness. So this is an example of those long, sweeping fascicles. And you can see that this very tiny vessel jumps out because it's darker than the surrounding lesion. This is a paler photograph, and you can see this fibromatosis infiltrating into pancreatic tissue. Very, very impressive. And I want you to notice the vascular pattern. You can see the myofibroblasts in the background. You can kind of make out their stellate cytoplasm. This is a very tiny vessel, another one, and they really pop out because the smooth muscle in their walls is darker than the proliferating lesion. Notice also fairly uniform cellularity. And at very high magnification, you have stellate cytoplasm in areas that aren't so fascicular, and each cell typically has a delicate macronucleolus in mesenteric fibromatoses. So just to line them up for a beauty contest, on the left, we have a GI stromal tumor, which is more cellular than the fibromatosis. But the key feature is that the gist is centered in the muscularis propria and the fibromatosis outside the muscularis propria. All right, there is a pitfall alert. You don't see too much of this fake kit staining in fibromatoses, but if you do excessive antigen retrieval, you will. I know that there are colleagues who like to say it's a non-issue. It is not a non-issue. This is a 2020 case that in fact did cause pause to a colleague. All right, so if you want to use beta-catenin, you're looking for a nuclear stain. You won't see it in GI stromal tumors. And here's what you might see in a perfect preparation. You use your blood vessels as your internal control. The endothelial cells can have cytoplasmic staining, but usually not nuclear. In this example, the vessel isn't staining at all. That's too good to be true. And you'll notice nuclear staining in the fibromatosis nuclei. Do not be expecting to see staining in every single nucleus. Even just 1 or 2 will do with the right morphology. This, on the other hand, is an overstained preparation, but you can still use it because if you have your internal control vessels, you can see that the nuclei are negative, even though there's a ton of cytoplasmic staining. Let's look at another immunostaining pitfall. This is a gastric Capacitysarcoma. Those are tricky because, of course, it's normal to see the background of plasma cells in the lamina propria of the GI tract. In this case, we're lucky. We have a little hemosiderin, and I think I have some hyaline globules in the field. Oh, yes, right here. I carefully covered them with this. Here's a nice example that has tons of hyaline globules. That's all we had back in the day before there was immunohistochemistry. as our clue. But nowadays, of course, if you get a Kaposi and you're a little nervous, you can confirm it with an HHV8 or LAN1 or LANA stain, depending on the term you like to use, and it stains the spindly nuclei. Again, not every single one. So there is a pitfall with these vascular tumors. You can often see KIT staining in Kaposi. You can also see the same darn pitfall in angiosarcomas when they occasionally affect the GI tract. Yours truly has been down that pitfall. This is a case that I misdiagnosed, and it's an angiosarcoma extending into the mucosa. Of course, if a GIST is extending into the mucosa, it's always very, very aggressive, but I was a fool. This is a little more pleomorphic than a GIST usually would be. And here's the KIT, but it's an angiosarcoma. All right, now let's just digress and have a little mini discussion of a few things about GI stromal tumors. They're the emperor of the muscularis propria, or the empress, depending on your mindset. And of course, as you know, they have spindle or epithelioid morphology. They usually have monotonous cells. And of course, we look for KIT expression, which we see most of the time, except for the PDGFRA mutated ones. And of course, we can see the same tumors that are not in the muscularis propria. We can see them in the omentum and mesentery and retroperitoneum, and even in some peculiar locations. So GIST accounts for a small subset of, I'm going to stick them in with sarcomas. Of sarcomas, we get about 5,000 new cases a year in our entire country. They're a low percentage of malignancy, but they, for years, recurred a lot because we had no targeted therapy. And of course, the presentation tends to be site-specific, but they present in older people. Now, I wanted to talk about how they're usually in the muscularis propria, but this was a Whipple, and this one happened to be in the submucosa, and it just makes a nice picture. And I think everybody here already knows that the thing we look for in GI stromal tumors is fairly monotonous spindle cells. This one is a bit on the cellular side. It might be a small bowel one. And then, of course, these gorgeous paranuclear vacuoles led our forefathers to think that these were smooth muscle tumors. They're not, but they're very characteristic, especially in gastric lesions. And often in GI stromal tumors, anywhere in the GI tract, we see nuclear palisading that's way better than the palisading you see in nerve sheath tumors. But you'll notice that there's no backdrop of lymphocytes. Of course, I've indicated some mitoses in this example, which was probably biologically aggressive. If they're epithelioid, again, we see fairly monotonous nuclei. You can see this one is extending almost to the gastric mucosa. So let's take a look. I'm trying to get the arrow to activate. So here's gastric mucosa. You can see that nicely. And you can see this epithelioid gastrointestinal stromal tumor. It's very easy to go down the tubes and think about carcinoma in this sort of setting. Here's a mitosis. This one probably was fairly aggressive, but you'll notice that the nuclei aren't that pleomorphic. They're not much bigger than the GI tract epithelial nuclei. All right, once in a while you see a dedifferentiated gastrointestinal stromal tumor. Luckily, in this case, it was pretty easy because, of course, we had a typical component on the left. It often happens after many cycles of tyrosine kinase therapy, but occasionally de novo, and it loses its usual markers, and you can really have a bear of a time diagnosing these if you only have the component on the right. So what's sexy now with these, of course, are the KIT wild type GI stromal tumors. And then, of course, there are familial ones in patients who have germline mutations of KIT or PDGFRA. Patients with neurofibromatosis can have gastrointestinal stromal tumors. They're often in the small bowel. They're sort of surprisingly indolent, and they have no KIT mutations, but they're KIT positive. So you'll be able to easily diagnose them, no problem, because of some peculiar interaction between the KIT gene product and the neurofibromin gene product, or that, NF1 gene product. And then, of course, there is, and let me get this out of the way, there is the Carney's triad, and I always have to check, which is epithelioid cyst, paraganglioma, and pulmonary chondroma. And then we get into the weirdo wild type GIST. We mentioned the NF1 associated one, and the one that we're all trying to make sure we don't miss is the succinate dehydrogenase deficient ones. They probably account for about 7% of GISTs. There's one study from the Brigham that makes the figure higher. I think that's probably fake because it's a referral center, whereas the 7% is old AFIP data, which was just all comers from the Army or the military. These tend to be in children. They're in the stomach, and they're epithelioid with plexiform growth, but they peculiarly have an indolent course with lymph node metastases. The usual recipe we do for GIST doesn't have any meaning in these, and they don't respond well to targeted therapy. So this magic subset is associated now with the Carney's triad of GIST, paraganglioma, and pulmonary chondroma. That is not familial. That has to do with promoter methylation. And then there's the Carney-Stratakis syndrome. And these folks are the ones with the germline mutations, and they get GISTs and paragangliomas. And any of the subsets can be mutated of that gene. So this is one of these SDH deficient GISTs, and you can see it's gorgeous. It's in the stomach. Now this little puppy has managed to get out of the muscularis propria, but most of these plexiform nodules are in it. And these tend to be epithelioid, very richly vascular. This is medium power of 1. And this is super high power of 1. And you can see that the tumor cells are small and monotonous. I've given you an internal control, endothelial cells. They're always your friend if you're doing mesenchymal pathology for an internal size control. And of course, these are the ones that spread to lymph nodes, but still have indolent behavior. So this is an SDHB stain, which picks up all the different SDHs. There's also a separate one for the alpha subunit, so you can pull that out, but the others you really can't. And you can see that every cell in the body has SDH because succinate dehydrogenase is part of the Krebs cycle. So you always have good internal controls, and you're looking for cytoplasmic loss in the tumor. You already have a hint because usually it's going to be a child, and you'll see the plexiform growth. Once in a while, these SDH deficient GISTs can have these very bizarre nuclei, which is very unusual for GISTs. You can see them in the lower right of this particular tumor, and they can be very bizarre, but often the mitotic activity is not commensurate with the atypia. Okay, so of course, those of you who do renal pathology know that there are SDH deficient kidney cancers that have bizarre cytoplasmic inclusions. And then, of course, we know to look for it in paragangliomas or pheochromocytomas. All right, let's keep on enjoying. Gastric mass from a 57-year-old woman. The surgeon insisted that we do KIT mutational analysis at the time of the operation. So you already know it's not a GI stromal tumor. And here it is. And those of you who know about this already know what it is just by our friend, the lymphoid cuff. So here's our friend, the lymphoid cuff. Whoops, it was in the muscularis propria. And notice there's a backdrop of lymphocytes. If you thought this was a GIST, this nuclear atypia would really give you anxiety. But you'll notice there's kind of a loosely palisaded pattern, and very loosely. You have to be imaginative. And you can see this kind of degenerative atypia in this case. So hopefully many of you already recognize this. This is a gastrointestinal type schwannoma. They usually arise in the stomach, and they always involve the muscularis propria, or I guess you can never say always in medicine, but virtually always. Sometimes you'll see them up in the submucosa as well. And you can see them anywhere in the GI tract. They're just rare everywhere but the stomach, and they're not common there. They're weird because lesions classified as GI schwannomas are different from conventional somatic schwannomas. They often lack a good lymphoid cuff, they have a good lymphoid cuff, and they often lack a fibrous capsule or vascular hyalinization. And they only sometimes show those degenerative nuclear features, and you won't find much mitotic activity in them. So another peculiarity of them is they tend to lack alterations in the NF2 gene, which are very common in sporadic conventional schwannomas, and of course in neurofibromatosis type 2 in patients who have lots of schwannomas. And then weirdly, GI tract schwannomas often don't have the calretinin expression, whereas other ones tend to have it. So this is a beautiful example of imaging followed by a resection. This is a gastric mass. It's mostly involving the muscularis propria, and we can see that very well on this resection. And of course, I'm running the arrow over the mucosa. So here's our friend, the lymphoid cuff. Of course, I know I've seen it when the colleagues do mucosal biopsies, and then somebody ends up working this stuff up for a lymphoma because they didn't manage to look up the imaging features. So this is that sort of vague palisading, and notice the backdrop of lymphoid cells. And again, plenty of chronic inflammation in these. So they're pretty easy to pick out just on the H&E. If you're nervous, of course, get yourself your favorite marker of Schwannian differentiation. I'm old, so I'm accustomed to using S100 protein, but those of you who are young and smart probably prefer to use SOX10. Either one will get you the answer. All right, so we'll line them up for a beauty contest. So on the left, we have the GI stromal tumor situated in the muscularis propria, more cellular than the schwannoma on the right. And of course, the gist lacks the lymphoid cuff, which is our friend. Muscularis propria some more, GI glomus tumors. They're usually, again, in the muscularis propria of the stomach. The median size at detection is a couple of centimeters, and they can erode into the mucosa and result in horrendous melena. And most of them are completely benign. And once in a while, there is a lethal course, and it's really hard to predict. So the key is that they live in the muscularis propria. And you can see that beautifully here. We're again in the stomach, in the muscularis propria. And if you're thinking of just okay, but it's a little too vascular, I tend to mistake them for neuroendocrine tumors. But if you're the lucky guy who gets a frozen on these, your good luck is that they're in the muscularis propria, whereas a neuroendocrine tumor is unlikely to be. This is high magnification, and you can see that there's a nice basement membrane around each cell and that it's massively vascularized. So of course, glomus type cells are modified smooth muscle cells, so they express smooth muscle actin and calponin and even H-caldesmon, but no desmon. And if you'll get yourself a basement membrane stain, it shows you that beautiful network around them. Mercifully, there are no KIT mutations or KIT staining, but the pitfall with these is that they express synaptophysin. So you can really mistake them for neuroendocrine tumors. Luckily, they lack chromogranin and keratin. And years ago, Christina Antonescu ground them up and found that they have a characteristic translocation and fusion, which goes along beautifully with the monotonous nuclear features. Here's a nice example of smooth muscle actin staining in a GI glomus tumor. Here's that beautiful net-like arrangement with a basement membrane stain. Again, you don't really need to do these. They're kind of H&E diagnoses if you have a good sample, but if you don't, they can be very helpful. Here's your pitfall. Synaptophysin can actually be pretty strong in GI glomus tumors, but of course, as mentioned, chromo and keratin will be negative. So this is, on the other hand, a well-differentiated neuroendocrine tumor. It lives where the neuroendocrine cells are, at the junction of the mucosa and submucosa. So this was an endoscopic mucosal resection. And so again, another beauty contest. Our glomus tumor is in the muscularis propria. Our net is at the junction of the mucosa and submucosa. Sure, it can extend into the MP, but you'll find that mucosal component. So if you're doing a frozen, it can really help. Let's work into the submucosa. We're reaching the capacity. We're getting close to the end. And the key thing to know about there is inflammatory fibroid polyp. It was described years ago, actually in the late late 1940s, I guess right after the war, by a Czech pathologist. And when I'm not sure if I'm pronouncing it right, Vanek, first described these, he described 6 lesions. He was from Pilsen, where the beer comes from. And he described gastric lesions, and 5 of them were in the antrum. So the current term was coined by Elston Hellwig at the former Armed Forces Institute of Pathology, inflammatory fibroid polyp. And we thought that they were reactive, and I certainly was taught that they were reactive back when I was a resident and there were dinosaurs on Earth, but they're almost always in the stomach. They account for about 1% of stomach polyps once you remove the fundic gland polyps. So, because there's so many of those. So you take those out, and then with what you're left, IFPs account for 1%. They're virtually always in adults. Of course, the familial ones in patients with PDGFRA germline mutations can be in children, and ever so rarely in children sporadically. So what do you see? Well, they live in the submucosa. So it's got a smooth mucosa, and if it doesn't ulcerate, you see this just lovely smooth lesion. Unfortunately, you can have ulceration frequently, and of course, the presentation has to do with the site. So this is a small bowel one, which resulted in intussusception, which is the case about 50% of the time. This is a gastric one that resulted in gastric outlet obstruction, so an antrectomy was done. And this is what a big one might look like that has caused intussusception. So you can see this is small bowel, muscularis propria. It's centered in submucosa, but has minor extensions into muscularis propria. And even at this power, you can make out that there are little lymphoid aggregates in the thing. And this one really shows the lymphoid aggregates. And by the way, the resection was not done for this one. This was separate from a separate gastric carcinoma. But what you'll notice is all the lymphoid aggregates. So then you say, oh, well, why isn't it a schwannoma? It has a lymphoid cuff. Well, because it's in the submucosa. So it's all about the layers. Okay, this is one showing a very characteristic feature, which is the whirling of the lesional cells around blood vessels. Some people call that onion skinning. And often you see these cute little giant cells, but a big helper is the eosinophils, and they're almost always quite numerous. And here's a beautiful example showing that whirling around the vessels. And again, remember, we're in the submucosa. So I was taught that they were reactive, and now we know that quite a large percentage of them have platelet-derived growth factor receptor alpha mutations, just like a subset of gastric cysts, but these are always benign. If you do immunostaining, you'll get a fibroblastic signature, and the consistent immunostain positivity is CD34. If you have PDGFRA, you can try it, but it only will stain between 60 and 70% of cases. Luckily, you don't get tripped up with kit staining. And here's a nice CD34 immunostain in an inflammatory fibroid polyp. Okay, so I'm going to conclude with a discussion of some mucosal nerve sheath tumors, and here we go. So a cecal polyp found at screening colonoscopy. We've reached the mucosa, and here it is. So hopefully the residents are noticing that it's mostly in the submucosa, but it does have some extensions into the mucosa, so I'm cheating a little bit. Here it is. And it has some nuclear atypia, but I haven't shown you mitoses. And it has some mineralization. So hopefully you all have an idea. And this is, of course, a colonic granular cell tumor. Most GI tract granular cell tumors are found in areas of squamous mucosa, such as the anus or esophagus. And the skin, of course, is the most common site overall for granular cell tumors. Rarely you do get to see them in the colon. They tend to be on the right, and they tend to have all these degenerative features like big nuclei, mineralization, and some nuclear atypia. And they can recur because they can be tough for the endoscopist to remove. but I have yet to find a convincing example of a malignant colon granular cell tumor. However, there are bona fide examples of esophageal malignant granular cell tumor. So I'm sure eventually someone will report a good one in the colon, but so far they've behaved just fine. This, on the other hand, is the pitfall. If there are any first-year residents, this will always be on your examinations. I believe this was actually anal, even though I labeled it esophageal. But granular cell tumors in squamous mucosa get this bizarre pseudoepitheliomatous hyperplasia associated with them, and you cannot pay attention to this. A clue that this stuff is fake and not real is that you can kind of make out the cell, what are they called? The intercellular bridges between each cell. And usually cancers don't do that, but it's very, very scary. Okay, and of course you can always stain your favorite stain for neural type differentiation in granular cell tumors. This is an S100 protein. Another thing that you will see is the so-called Schwann cell hamartoma. And it's not really a hamartoma, but when Dr. Hornick described this thing a number of years ago with his colleague, Dr. Gibson, they were trying to just underscore the fact that this is generally not part of syndromes in contrast to mucosal neuromas. So Schwann cell hamartoma was the term they coined, even though it's not exactly a hamartoma. I will tell you, though, that occasionally patients with P10 hamartoma syndrome, or it's also called Cowden syndrome, can have Schwann cell hamartomas as part of their polyps. So this is how Schwann cell hamartomas look. You see these vaguely palisaded. So here's like a group of nuclei, none, group of nuclei, none, group of nuclei, none, nuclei in the lamina propria, just going between the glands. And the cytoplasm is very thick and pink, such that you often might think of a smooth muscle tumor. Here's another one, and I just want to show you that kind of dense fibrillary bundled cytoplasm. And here's super high magnification. I'm trying to show you this dense bundled fibrillary type cytoplasm. Of course, you can see these intranuclear inclusions in these, just like in any Schwannian type tumor. And of course, if you don't recognize it, you can always get yourself an S100 protein or SOX10, whatever your favorite stain is. Remember, I'm old, so I like S100 protein. The other thing that's similar to this that you will see is something that's been called benign fibroblastic polyp of the colon, or perineurioma, depending on whose paper you read. They were described years ago, actually, by Dan Pat Jane, who's at Yale. And people began to notice all these funny little nerve sheath tumors as soon as everybody could get colonoscopy for free, which was starting in about 2001. So before that, you had to have a special high risk. And then in 2001, the powers that be decided, no, everybody should get screened for colon cancer. So these things were believed to be fibroblastic, but nobody thought of perineurial. And then other colleagues started staining them with perineurial markers, and darned if they didn't stain. Some people think they're just reactive. I suspect that's wrong, but I haven't done anything to prove it. But again, you see them in the lamina propria, sometimes intimately admixed with all of the various serrated polyps. Well, not all of them, but with hyperplastic polyps and sessile serrated adenomas. And if you stain them, they really don't stain for much of anything unless you think to add a perineurial type marker. So here's a nice example of one of these perineuriomas associated with a serrated polyp. I guess probably we'd call this one a sessile serrated adenoma / polyp / lesion. I would imagine the Minnesota viewpoint would be more adenoma, but I could be wrong. And you can see it looks a little bit like the Schwann cell hamartoma, but it differs. And it differs in that the individual cells have these long cytoplasmic processes, as indicated by the arrow in this image. And because I'm a dirty old lady, it makes them look like, in my view, it makes the cells look like spermatozoa. So you don't have to see it that way, but here's another example. of a perineurioma, and I've indicated the long cytoplasmic processes. Here's an even more dramatic example indicating the long cytoplasmic processes. And of course, I took this picture under oil immersion. So if you do EMA, it probably won't stain this strongly. You'll look and look and look and find a little wisp, and nobody has Claudin 1. Many labs do have GLUT1, and these things stain with it. Don't forget, of course, that erythrocytes also stain with it, so you can get fooled when you first pop up your slide. So just to remind you, another beauty contest with the perineurioma on the left with the long cytoplasmic processes and the Schwann cell hamartoma on the right with the thick cytoplasm. So the main thing I'd like to end with is to point out with mucosal nerve sheath tumors, which you will see, they're generally going to be benign. You don't need to worry about a GI stromal tumor, because if it's a GI stromal tumor in the mucosa, it will have ugly features. It will have mitoses. You might have imaging results that indicate a large mass. On the other hand, you don't want to miss the so-called rare mucosal neuromas in patients with MEN2B. And I can never remember, so I reminded us it has medullary thyroid cancer, pheochromocytoma / paraganglioma, and then these weird neuromas. This is an EMA stain, and this was a mucosal, actually this was submucosal, and you'll notice that there is a cuff of perineurium around the lesion, and that's kind of a special thing about these so-called mucosal neuromas. Here's one that was in the lip of a young patient, and you can see that it's sort of plexiform, they're neural, and you can kind of make out even on H&E that each one of these nodules has a cuff of perineurium. And here it is at higher magnification. So this really is the mucosal neuroma. Here's a case that I almost missed. The colonoscopist described that there was a slight bumpiness to the mucosa, and at first glance, it looks like nothing. And then you see this little guy and this little guy, and my little antennae went up. Here it is at higher magnification. This is an S100 protein in that case. For the first year residents, remember that for an S100 protein stain to be considered bona fide and doing its job and staining something, you should see nuclear and cytoplasmic staining, and we do. And then here was the epithelial membrane antigen. So you can see a nice little cuff of perineurium around one of these things. So of course, this is the kind of case to flag, to get in touch with a clinical colleague to make sure that some observations are made on whether the patient might have a multiple endocrine neoplasia syndrome. So I'd like to end by pointing out that I've whirlwinded through a lot of stuff, but as you approach mesenchymal GI tract neoplasms, do consider what layer you're in, consider imaging characteristics. Most of them actually are, in the end, H&E diagnoses. Sure, you can get stains, but you use the H&E to tell you which one. And then, of course, there are some cases for which we do want a little hand-holding from ancillary studies. This is a street in my former city, kind of cute. And with that, I close and thank you. So I will stop sharing. And here we are.
Please, thank you very much. That's very awesome, and quite well done. That the organization is just very easy to follow. So I appreciate that. So we have time for some questions, and I can just start us off before the next person comes up with their question. So to answer your first, one of your questions during your talk, yes, in Minneapolis, we still stick to SSA. When we talk about those serrated neoplasms, we are not going to lesions or polyps or anything yet, still SSA for us. My question has to do with the succinate dehydrogenase deficient lesions, especially the GIST. So you talked about the methylation, the somatic methylation in Connie's triad that happens. So how does SDHB immunohistochemistry work? whether you are dealing with the methylation or we are dealing with the germline mutated SDH. Does it really matter? Or is there any way to differentiate?
No, you can't. Okay. No, it's just like the mismatch repair proteins. You can't tell whether it's Lynch or sporadic. I assume that you perfectly know that perfectly well, and you just wanted to illustrate it for the residents, and that's exactly right.
Yeah, that's good. So thank you very much on that. Any other question from the audience?
I have a quick question, Delhi. This is Pari.
Sure.
Dr. Montgomery, this was an excellent presentation. Thank you very much. Just a quick question on the glomus tumors that you mentioned can be synaptophysin positive in the stomach. Have you seen synaptophysin positive stain in the glomus tumors elsewhere in the body?
Yes, I probably should have mentioned it. Yes, it can pop up anywhere just to fool us. So do know about that. Thank you for mentioning that.
Okay. And just another follow-up to that. So there is this immunostain INSM1 that some people use nowadays for neuroendocrine differentiation. It's supposedly more specific than synaptophysin in some cases. Do you think that might be useful in the setting of a gastric tumor that's positive for synaptophysin and you're thinking might be a carcinoid?
I suppose you could use it and it would probably help, but you'd probably want to do a keratin instead, but up to you.
Thank you.
Thank you. Any more questions? Okay, so I think I will end it here to give Dr. Montgomery a few minutes to rest before she begins our next session with our residents. So once again, I want to really thank you for accepting our invitation. And for those of you who would like to have more chat with Dr. Montgomery, she's going to be our guest at the ET Bell Symposium starting from Friday morning. So feel free to drop in and say hello to her. So this is the end of the session. Thank you very much for your attendance.